this topic, the topic of my talk, has been repeatedly already mentioned in the previous sessions, and also Professor Madersbacher had mentioned something about changing concepts. And the optimal management of oligo-metastatic prostate cancer is one of these areas. Why? Why are there thoughts that cytoreductive surgery or radiotherapy might play a role in prostate cancer? Well, we do have cancers where there is, based on prospective randomized trials, evidence that treating the primary tumor improves the survival. This has been shown for colorectal cancer, for renal cell cancer, and for glioblastoma. So why not also for prostate cancer? Well, you know, in the time of sharing slides, the rationale for treating the local in oligometastatic prostate cancer is to potentially eliminate therapy-resistant, potentially metastatic cell clones. And in most cases, this is the first step in a multimodal therapeutic concept together with radiotherapy and other forms of therapy. The aim of such a concept is to, of course, to improve progression-free and overall survival. This is the major goal. And the second goal is to prevent local progression, that you don't see the problems that we repeatedly see with locally advanced prostate cancer, hematuria, obstruction, retention, and things like that. So this is a patient who falls into this category. A 56-year-old man, PSA 33, 8 out of 12 biopsies positive, Gleason score 8, with a solitary bone metastasis, and let's assume all other screening tests are negative. So is this a patient for radical prostatectomy? How to advise such a patient? And actually, you can only advise a patient based on clinical data. And I will show you 4 studies now that try to elucidate a little bit this issue. And you will see that none of these 4 studies is perfect or is probably even good. This is a study that is frequently cited and presented in all the presentations on this topic. This is a study from the Munich Cancer Registry. What have they done? They have worked up their cancer registry database, and they have found a fair number of patients with positive lymph nodes that either surgery was stopped, the surgeon just closed and said, we do something else, or the group in blue, there where the surgeon decided, let's go on and do radical prostatectomy. And this is the overall survival curve, and you will see a dramatic difference in favor of surgery, with a difference in survival of almost 6 to 7 years of patients with positive lymph nodes. The problem here, this is not randomized. It can well be that the surgeon in this group decided these are the fitter ones. Let's go on for surgery. Those are the unfit ones. Let's don't do radical prostatectomy. So there might be a significant bias in there, but an indirect hint that that probably makes sense. Similar analysis, SEER database, huge US database, looking at patients with metastatic prostate cancer that either had some form of radiotherapy or radical prostatectomy or non-surgical, non-radiotherapy group. Again, a huge dramatic difference in survival, and those that had local treatment did much, much better. But again, is this a definite does this prove the concept? No, of course not. It is not randomized, and again, there might be huge biases in there. The numbers are dramatically different, but again, it is an indirect hint that local treatment in metastatic disease might play a role. The third study that I would like to show you is an in-press paper in European Urology, 18 patients, very small cohort of patients treated in Italy with metastatic disease. And what this study shows, and what I think you can conclude, is that when you do radical prostatectomy in metastatic patients, this can be done with an adequate morbidity. The morbidity of the approach is not so much different when you do radical prostatectomy in non-metastatic cases. They have shown very good outcome in this cohort. So the conclusion is of this series, it is of this third study, it is feasible. This is for sure the case. It has an acceptable morbidity. This is also true. Whether this makes sense from an oncological standpoint, nobody knows. And this is the fourth study that I will show you, also repeatedly cited in the literature. This is, that you have to understand it, a retrospective case control study. We always call this is the worst study design that you can choose. What Axel Heidenreich has done is, he does this procedure, he does surgery in oligo-mestatatic disease, and he has compared the outcome of these patients to a group of patients that only received androgen deprivation therapy. He found almost 50 patients that fit into this category. What is interesting, and I'll show you a slide in a minute why I believe the concept of Heidenreich is interesting. He gave all these patients hormone therapy for 6 months. And only if they responded well, if they received a PSA of 0 of less than 1, then they went on to surgery. Why is this neoadjuvant treatment, or however you call it, of hormones important? We know from M1 disease, this comes from a very large randomized study, that if you respond very, very well to primary hormone treatment within 6 months, if you reach a PSA value of less than 0.2 was the cutoff here, you have an excellent long-term survival. If you do not achieve this value, your survival is poor, and probably it makes no sense to do active radical treatment in this cohort of men. So the idea of neoadjuvant treatment with hormones makes sense. These are the results of the Heidenreich study. Remember, it's not a randomized study. This was a group that received radical prostatectomy, and this was a group that did not receive radical prostatectomy, but he tried to match these groups as good as he can. Well, there seems to be a survival advantage, cancer-specific survival, a moderate advantage in cancer-specific survival, a more prominent advantage in overall survival of 6 to 8 months. So there seems to be a slight benefit in doing radical surgery in patients with metastatic disease. This is not convincing regarding survival. But it has one clear advantage, and that has been repeatedly emphasized, that you avoid local failure with all the complications. In the non-surgery group, 11 patients required surgical or percutaneous interventions due to hematuria, obstruction, hydronephrosis, and things like that. And these are the conclusions of the Heidenreich paper. I think this is fair what he said here. It might be a treatment option in a multimodality treatment regimen. This is how it should be done, and this study is running. This is a prospective randomized German study where patients with 1 to 5 metastatic lesions to the bone, locally resectable disease, PSA of less than 200, these patients had to be asymptomatic and minimally symptomatic, and these patients are randomized 1-to-1 to cytoreductive radical prostatectomy plus hormone therapy. It's not written here. So radical prostatectomy plus hormone therapy versus hormone therapy alone. These patients are followed, and then you will see what the data will be in about 2 to 3 years probably. This study is recruiting fairly good. So this is my last slide. It is a new concept, trying to managing localized disease, the local primary in oligometastases. When you do radical prostatectomy in these patients, it is associated with an acceptable morbidity. This has been shown in 2 studies. There is the avoidance of local complications. This is certainly a major advantage when you do this approach. Whether this impacts survival, we simply don't know. The studies that I have shown you, the 4 most relevant ones, provide indirect evidence, but this is no definitive proof. This approach is, however, increasingly used also due to better imaging, but it has to be still considered experimental. Randomized trials are underway, and the definitive answer, and then it will enter the guidelines based on level 1 evidence, is available in probably 2 to 3 years, and then we can provide a better advice to our patients. Thank you.